I'm aware we're in the last 6 minutes. I would like to just pick up a couple of questions. This is a question for you a bit, Lynn. How do you manage with a dismissive clinician, one who's actually got no intention of listening to you? And I remember we used to do an exercise on a couple of self-management courses around working with your healthcare professional. What are some of the common issues you have? And people would come up with various things, and this was a common thing. It's like, well, great, I've learned to self-manage, but my clinician doesn't listen to me. Lynn, any thoughts around, other than Andrew's training?
These days, if I meet a dismissive clinician, I don't feel bad about it. I just go away and I will go and talk to other people. It doesn't bother me. In the past, do you remember those steps when I was talking about going up from level 1, 2, 3, 4? In the past, if I had met a dismissive clinician and I might have been at level 3, that dismissive clinician would have sent me straight back down to step 2, because I would take it on board and I blame myself and think I was rubbish and I'm not doing things right. So so self-management support is so critical when people are moving up that patient activation, those steps. If you don't have the right support, you are easily knocked back, and clinicians can knock patients back. And I would say it's quite difficult, isn't it? I mean, I these days, whenever I meet clinicians now, if I do meet a clinician like that, I take it upon myself to try and do some training and improve their practice. But I'm not knocked back anymore. It doesn't bother me anymore. And what I would do is not bother going and seeing that person again.
Andrew, a common question, but one which has come up, is the whole thing around time. You look at the T-GROW model and there's different elements and everything else, and people go, oh God, that's a lengthy process.
Our conversation was 10 minutes, or just under actually. So it is an investment of time. I've worked with thousands of GPs learning how to use the principles in their very, very small windows. So what I would say is that coaching operates at different levels. So there are techniques like the ones we just showed you. Then there are skills that you would use, sort of the listening, the rapport building, the various challenging skills that I was using during the conversation with Jim. And then there's a mindset that you can think about. So in my experience, you can bring the mindset to every person that you're working with. Like, do you believe people are resourceful? Are you willing to treat people like they've got expertise in their own life? Do you want to hold more of a mature adult conversation with someone rather than be in the expert role and treat someone like a child? So these are part of the mindsets that you can bring from coaching development, coaching training, that you can bring into all of your consultations, and then you can use the skills to have productive conversations as well. But then sometimes, and depending on your role, you might use the techniques. Some people with a bit more time use the techniques a lot. Other people just use coaching skills to really enhance their open questions or having a goal for a conversation. So I think it's kind of what of it suits the person's role and what they're trying to achieve with and for the person they're working with.
Things like a T-GROW model just show the importance of understanding that these techniques are rooted in sort of firm evidence-based models and things, and these models, hence why training is so important, that these models can actually help hold practitioners and things, and makes it safe for the client, but also safe for the practitioner. One other question is, again, a common theme. Lynn, you were talking about activation level 1, so very passive, and there's a comment here around what about people who seems to be doing things which seem to be detrimental to their health, excessive drinking, overeating. How can we help people who seem to be sort of self-destructive and not interested?
I'm having this at the moment with my 92-year-old mother-in-law who drinks excessively. And it's about, I'm not going to stop you drinking. However, I need to just make you aware of the damages that you might be doing, or how it's impacting on other people, or asking them, how do you think that might be impacting on other people? What do other people think? I just think it's about we need to be open, and we're not there to stop somebody doing it, because actually we can't stop people doing it. It's their decision. So it's about a little bit like you were doing with Jim, Andrew. It's about supporting them to be uncomfortable in the decisions that they're making. And then once they've acknowledged that level of, discomfort in their lives, then maybe they might make some changes.
Okay,
it's not easy, but I don't think we should shy away from it.
So that's back to Andrew's point around exploring the reality, creating that dissonance between the reality and people's perceptions of what's going on.
Well, and I also think maintaining the duty of care that you have in your role when you need to intervene.
Okay, I'm aware we're up to time and actually sort of spilling over time. A huge thank you for everyone who attended. Thank you to everyone. Thank you.
Thanks.
Thanks, Jim.